show.
Well, okay, we have it. Thank you very much. So now I will present a most challenging video on new insights about retrolenticular space. It's not going, it's not running. That's another problem.
Oh my God.
No. Okay.
Best open presentation.
Okay. Disclosure is quite important in this case because I will mainly speak about the knowledge that I had by developing the back in the lens. The space of Berger, I know you hope it, consists about the anterior capsule, posterior capsule, anterior hyaloid, and ligament of Wieger. And in this young adult's eye, you will see the vitrolenticular interface. The red is the posterior capsule, the green is the anterior hyaloid, and the circles is the Wieger of ligament. When you separate the green from the red, so the anterior hyaloid from the posterior capsule, in normal eyes, ligament of Wieger is still there. But if you have a detachment, like in this case, the green is far away from the red, so the anterior hyaloid is far away from the posterior capsule, then you will have a floppy capsule, a floppy posterior capsule, and it is a little bit more difficult to drag the posterior capsule in order to make the opening. However, I will inject through that little opening, I will inject the OVD. And this little air is not meant to be, but anyway, it will help you understand that by injecting more and more in the space, that air bubble will go more and more laterally until it reaches the area, the end of the capsule bag. Now, what we don't know in the eye is the liquefaction degree of the vitreous. And therefore, it is very important to have a good counter pressure from the anterior segment. So fill the anterior segment very well. Now here you see the prolapse of the anterior hyaloid through the posterior capsule because there is an enormous liquefaction of the vitreous in a pathological eye. That's the reason why in all cases it is much better to inject viscoelastic material through the opening in order to protect, to push back the anterior hyaloid, and then you can perform your posterior capsulorhexis in a very, very safe way, and you have not to fear to damage your anterior hyaloid at all. I think that never listen to the people who say that you can do straight away your posterior capsulorhexis, always separate it. Now, if you have on your slit lamp a patient where you have in the visual axis, whether you have dots and whatever in the vitreous, where are they located? Well, the OCT will help you. And in this case, there is a detachment of the anterior hyaloid, and you will see a lot of dots in the space of Berger, also in the retrolenticular space, of course, as well as you will have some strands there. So, it is also the common knowledge that in case of persistent fetal vasculature, most of surgeons will use a pars plana approach. It is not necessary, because I will show you that, in fact, in patients with PFV, the anterior hyaloid is, in most of the cases, you can detach it from the posterior capsule. So that means that you can perform an anterior approach to handle this stalk and to cut and to cauterize this stalk. Continue your PCCC just like normally, because it's free from the anterior hyaloid, and that's it. Now, for those who are the poor believers about that area of the Berger space, I will inject in this eye, I will inject some Kenacort in the space behind the posterior capsule, and you will see that not one molecule goes or escapes that space. So that means that that is the role of the Wieger ligament, is to try to avoid cells moving. Never ever forget about the retrolenticular space. It is the real space and most important to support the capsule and to support accommodation. Thank you very much.
Thanks,